Welcome to EconTalk, part of the Library of Economics and Liberty. I'm your host, Russ Roberts of George Mason University and Stanford University's Hoover Institution. Our website is econtalk.org, where you can subscribe, find other episodes, comment on this podcast, and find links and other information related to today's conversation. Our email address is mail@econtalk.org. We'd love to hear from you. The podcast you're listening to is a little bit of an experiment. We've been releasing EconTalk on the web every Monday morning for a little over a year. But this podcast is a bonus. It's an in-depth look at the issue of administrative costs under a single-payer healthcare system and how much money might be saved if the U.S. adopted a system more like Canada's. The issue came up in my conversation with Arnold Kling a few weeks ago, and I thought it would be interesting to go into it in more depth. So I interviewed Henry Aaron of the Brookings Institution, and along the way, we also talked about the role of insurance in healthcare reform. It's a little shorter than usual, just over 35 minutes. If the topic isn't of interest to you, we'll have our regular Monday release in a few days, a full-length conversation with Cass Sunstein about worst-case scenarios, dealing with low-probability, catastrophic events. And if you like the idea of a bonus or extra podcast, particularly one that goes into more detail on a particular issue like this one, please let me know via email, mail@econtalk.org. Thanks. A couple of weeks ago, I interviewed Arnold Kling, and we talked about the economics of healthcare. One of the issues that came up is the high cost of the U.S. system relative to other countries, and how little those extra expenditures appear to have increased life expectancy. In an earlier podcast, Robin Hanson and I discussed the same issue. There are a number of possible explanations why expenditures may not lead to longer life. Perhaps the effects haven't been measured correctly. Perhaps Americans spend a lot more in healthcare than other nations and in return receive a higher quality of life. But one response to the high level of U.S. spending and the apparent small return is to reorganize the U.S. system with an eye toward eliminating wasteful expenditures. One popular proposal is to go to what is usually called a single-payer system, where that single payer is the U.S. government. Instead of having all these different insurance companies covering healthcare costs, replace them all with taxpayer-funded coverage. One potential virtue of this system is to simplify paperwork that many doctors and hospitals do now. Now, there'd be many costs and benefits from such change. One benefit might indeed be lower costs from administrative compliance with the numerous private insurance companies dotting the health insurance landscape today. But Arnold Kling dismissed that argument, saying that the administrative costs are relatively small. He argued that the reason we spend more in the U.S. relative to single-payer systems outside the U.S. is simply because we provide a lot more services. Hoping to keep those services and save money via efficiencies of a single provider is a fantasy. I then blogged on the issue at my blog, Cafe Hayek, and one commenter there, Ed, cited a New England Journal of Medicine article that claimed that administrative costs in the U.S. are not small at all. They're large. And they're large relative to Canada, for example, a single-payer system. That article by Steffi Woolhandler, Terry Campbell, and David Himmelstein argued that administrative costs in the U.S. are not small, they're huge. They found that the U.S. spent $294 billion on administration in 1999, actually $294.3 billion. I love that .3. It makes it sound so precise. That's 3 times the per capita spending of Canada. By moving to a single-payer system akin to Canada's, according to these authors, America could save $209 billion. While that's still only a small proportion of total healthcare expenditures in 1999, which were about $1 trillion, $209 billion is a sizable saving. The question, though, is it an accurate measure? Is that savings measure either the total expenditure on administrative costs of $294.3 or the potential savings of $209 billion? Are those accurate numbers? One of the issues we've been talking about here at EconTalk is the difficulty of accurate measurement and accurate analysis. So I thought it might be of interest to look a little more closely at this issue of administrative costs, see how reliable the $209 billion of potential savings is if the U.S. moved to a single-payer system like Canada's. Would we save $209 billion from greater efficiency? I think it's a nice example of how elusive the truth can be in these kinds of policy discussions. My guest today to discuss these issues is Henry Aaron, a senior fellow at the Brookings Institution, who has written extensively on the topic of healthcare and who has written a brief critique of the Woolhandler, Campbell, and Himmelstein paper, which, by the way, both the original article and Your critique appeared in the New England Journal of Medicine, which most of us don't have access to, and I thought it would be nice to get our listeners exposed to some of these economic issues that are so related to the public policy concerns that are so topical. Henry, welcome to EconTalk.
Glad to be with you.
So first off, what's your general perspective on this whole issue of administrative costs and potential savings?
My general slant is that we have an extraordinarily complex set of arrangements. I don't think using the word system is appropriate for the arrangements we have for paying healthcare in the United States. There's very little standardization from one healthcare plan to another. That means that physicians' offices and hospitals have to be prepared to handle all kinds of different billing forms. We bill for individual services, which means that records have to be kept by all providers so that they can justify their bills. And that results in a system that is very expensive and very complicated, and I think costs more for administration than any kind of social benefit we get from it. At the same time, we're underspending on aspects of administration that some other countries are currently investing in. Specifically, we don't keep very good records of what works and what doesn't. A number of other nations have established agencies that try to evaluate just what new technologies are worth, what they cost in order to achieve improvements in health outcomes, and how they stand up compared to currently available treatments. We have, on a number of occasions, set up such organizations, but their lifetimes have been short and inglorious because they did what they were supposed to do. Namely, on occasion, they would come up with findings that particular new medical technologies weren't really worth what they cost, and that then led to political backlash that caused these agencies either to be terminated or to have their scope of authority severely limited. We need to spend more money on that kind of administration, which is a post-audit of what the healthcare sector is doing. And we could, if we had a more streamlined system, spend a lot less on arranging payments for specific services.
Before we get into the details of the Canadian-U.S. comparison, which I do want to focus on, I want to stick with this point you've just made about what might be called efficacy or effectiveness. We had a podcast recently with Ian Ayres, who argued precisely for this kind of improvement over various rules of thumb that doctors may be using now. And he made the case that doctors are very ill-informed often about effectiveness. I want to ask you two things about that before we get to U.S. and Canada. One is it really so straightforward? Isn't it remarkable how often received wisdom about healthcare gets reversed by the latest study? I'm just thinking right now about the obesity findings that came out from the CDC, the Center for Disease Control, that argued that despite previous arguments that obesity was a killer, it now actually is either neutral or maybe a lifesaver if you're a little bit overweight. Do you think we can, given the complexity of the human body and the complexity of the data that would inevitably be involved, can we get reliable estimates of what's effective and what isn't?
Well, let me be a little technical for a second. Obesity is bad for you. Being slightly overweight is not. That's the current. Obesity is way overweight.
Correct.
But I think what we can do is not necessarily get complete accuracy, but we can get a better guide than current practice, which, as you said, frequently follows rules of thumb. A better guide than we now have. There's a group up at Dartmouth University under the It was set up by physician John Wenberg many years ago. Wenberg observed that across small areas in the United States there was an enormous variation in the frequency with which various medical procedures were used. Out of that finding has emerged something called, I think it's called the Dartmouth Medical Atlas, or some, I may not have the title just right. But what it does is a report on the frequency with which medical procedures of various kinds are used by state and by counties, basically Medicare service areas. For some procedures, the differences are relatively small, and you'll be struck by what relatively small means, maybe 2-to-1 differences. But for some medical procedures, the differences across these areas are 8, 9, and 10-to-1. They can't both be right at the extremes on that distribution.
Probably not.
There's been additional research which has found that at least for certain conditions, medical outcomes are not better where more procedures are used. The standout example is in the treatment of coronary disease, where very high rates of coronary bypass surgery and angioplasty don't necessarily lead to better health outcomes. What really is very, very important in the treatment of heart disease is that people get beta blockers after a heart attack and are put on aspirin, neither of which is very expensive.
Right.
And not all doctors do that. So what we have is enormous variations in the use of procedures that cannot conceivably be justified by variations in epidemiology, and some highly suggestive evidence that doing more isn't necessarily doing better.
Yeah, and that's related to this, of course, the issue that we started talking about over here and elsewhere, which is what are we getting for our money? I want to put that to the side now, and although I think the issue of information is very important, I think the key question there is who should use that information, who should have access to that information. And personally, I'd like to see more information provided to more folks in the decision making. The only thing I would worry about would be a top-down decision about what to do when, rather than having that be more diverse.
I think the power of information here could be very great. If an insurance company today says we don't want to pay for X in this particular, given this particular set of patient characteristics, they're in a weak position. If there's solid evidence supporting that position, then it's a very different story, and patients will react very differently.
Absolutely.
Right now, if the doctor says do it, the patient's reaction is, well, yes.
Sure.
Information could improve things greatly.
Yeah, no, I agree, and I personally, I'd like to see patients be a little more proactive. We don't have the incentives right now for that as much as I think we could. But let's turn to the U.S.-Canada administrative cost issue. So the study that was done in the New England Journal of Medicine found that by moving to a single-payer system, we could, in the United States, reduce total expenditures on administrative costs from $294.3 billion to a much lower number, saving $209 billion. Your comment immediately pointed out very quickly an error they made in their estimation. What was that error that made their estimate off by $50 billion?
Well, it's a question of relative wage rates across the two countries. The main point of my article, though, it was an editorial. The main point was that comparing administrative costs across systems is very, very, very tricky. There are a lot of estimates, and the data are seriously incomplete. Wohlhandler and Himmelstein have been writing articles similar to this one for a very long time. They have been arguing on a policy basis that the United States should move to a single-payer system. and have suggested that the savings from streamlining of administration under a single-payer system would be sufficient to pay for the additional services that would likely be provided under such a system to those who are currently uninsured. I actually don't want to get into an argument about the qualitative issue. I do believe that the U.S. system or set of arrangements for paying for health care is ridiculously convoluted and needlessly expensive. The point of my comment in the New England Journal was that there were reasons to believe that their estimate was too high, and I only focused on one in focusing on relative wage rates. There are a variety of reasons why it's probably too high.
Let's start with the wage rate issue, though. Just to explain that, because that's just a nice, simple example of how what seems to be an innocuous assumption was actually somewhat important.
Well, the basic point here is that in Canada at that time,
this is 1999.
The Canadian dollar was worth about 75 or 80 cents compared to the U.S. dollar. Now it's worth more. And for that reason, it was important to recognize that one of the reasons they spent less was that they were paying less for administration.
Administrative personnel
than we are paying here in the United States. The baseline also, there's another point, the baseline for estimating what a single-payer system would cost is modeled on the Medicare system. And there are a variety of ways in which the U.S. Medicare system generates administrative costs. They're not included in public spending on Medicare.
So, for example, this is one of the things I wanted to ask you about, not having read anything other than the abstract of the original paper. Complying with U.S. government health insurance, that is Medicare and Medicaid, obviously imposes costs on healthcare providers, doctors, hospitals, doctors' offices, hospitals, etc. Is that included in that? I assume that's included in their 294.
Yeah, I think it is, but let me give an example of one that isn't. Medicare is paid for by payroll taxes. Collecting payroll taxes costs money.
Sure, and has distortionary effects on work effort potentially, although the magnitude of that is often hard to estimate.
Yes, exactly.
But my impression is that, sort of the irony in this debate, my impression from my doctor friends is that Medicare and Medicaid is not a paperwork paradise. Quite the opposite. While there is this terrible complexity, I don't know if it's terrible, but it's a fact, this incredible complexity of the private insurance system, it's not as if you can comply with Medicare and Medicaid on a postcard. So I assume there are a lot of costs involved in the current system that are due to the current government role in healthcare, and if we move to a larger role for that, some of those savings wouldn't materialize.
That's right, but the single-payer option that those who advocate single-payer support would actually achieve some economies for providers relative to Medicare. Under Medicare, for still about 85% of enrollees, you're paying individual bills for defined services, or you're paying for a hospital admission. Under many single-payer systems, and indeed under many systems that involve multiple payers but still have a relatively small number of them, hospitals are budgeted. They receive flat sums. Then the hospital administrators, who frequently are nonprofit or private, they're in the private sector, they're not government employees in most countries, have the job of allocating the budgets that they receive to deliver care to as many people and in the best way they can. But they're not in the business of having to bill anybody for each individual service, and that can achieve very significant savings.
There's also a question of whether they underestimate the savings. We talked about how their estimates exclude any collection costs or distortions due to payroll tax funding of government-funded health care. But they also exclude, again, this is just my reading of their summary, they exclude health insurance company personnel. That is the fact that under the current system in the United States, there's a lot of health insurance companies employing lots of people. If we had a single-payer system, government employment would expand, but it might not expand as much as healthcare contracts, and health insurance, private health insurance employment contracts, and those would be additional savings they did not account for.
I think they count insurance loading charges, which should encompass that. If you catch them out in underestimating administrative costs, you will have achieved something that nobody else has yet done.
Let me give a quote from your editorial that I think is take us in a slightly different direction. That we did start in this direction, but I want you to expand on it. You said, quote, "Although differences between U.S. and Canadian spending on healthcare administration are probably smaller than Will Handler and colleagues suggest, they may be large. But so what? The most important question is what these differences should tell policymakers. I believe the answer is not much." End of quote. Why do you say that?
Well, the reason is, the most fundamental reason, in my opinion, is that every nation that is considering reforming its healthcare system inevitably has to start from where they are. That is to say, if we adopt some form of modifications in our healthcare financing system, it's going to take the form of gradual evolution from current arrangements. And that means that if the administrative costs are modified, those modifications are going to occur gradually over a long period of time. And we are going to have, we are not going to put the insurance industry instantly out of business. Any changes in the role that they play are going to be of an evolutionary nature. Meanwhile, that's going to occur. Those changes will occur not over months or even a small number of years, but probably over a couple of decades. Real healthcare spending goes up about 5% real a year, and that means that we double healthcare spending about every 15 years or a little less. So what we're going to have are gradual changes in the amount we spend on administration against the background of a very rapidly rising level of total healthcare spending. Yes, there is, I think, a potential for significant saving down the road, given the pace of advance of medical technology. We're going to be spending a great deal more on healthcare, and I think somebody who is doing a retrospective study in 15 or 20 years, even if we move to a quite different system, is going to have a hard time sorting out the savings that were actually achieved and it'll end up being a small percentage of the change in spending that actually occurs.
Well, let me raise it's an excellent point, raise a different issue. As an economist, the mantra of cutting costs for cost's sake seems bizarre. Focusing on total expenditures, focusing on costs, is really not the economist's normal way of thinking. Another commenter at Cafe Hayek, Charlie Quidnunc, pointed out, quote, "If profits and administrative costs are so terrible, why stop at eliminating them in the healthcare industry? Why not get rid of those pesky elements in other industries? How about creating a single provider information technology industry? Think about how much better computers would be without all that complex and expensive competition between companies. or single provider automobile industry, or single provider food companies? Why not have the government decide what a wholesome and nutritious meal should look like and eliminate all that expensive experimentation in fancy restaurants? Close quote. As being somewhat of reductio ad absurdum, but
Sure.
I think it makes a good point, which is that in most areas of competition in the private sector, we look at overhead, administrative costs, advertising, distribution. Some people point to them as wasteful, but we understand that those are often, almost always, the inevitable consequence of a competitive system that leads to lots of innovation. Yet in healthcare, that doesn't seem to perhaps be the case, at least in the highly regulated parts. In the unregulated part of healthcare surgery that I like to point to, given my love of competition, LASIK surgery, we see lots of improvements in quality and cost, and consumers benefit. We don't see that elsewhere. So my question is this, long introduction, sorry. Question is this, when you look at that crazy quilt, that hodgepodge of insurance compliance, that non-standardized set of forms and regulations that and rules that private doctors' offices and hospitals have to grapple with from the private insurance industry, why isn't there more standardization? Are there barriers to competition between health insurance companies across state lines, for example, that have created part of that problem, or maybe most of it?
Well, as far as the non-standardization in billing, which has bedeviled physicians and hospitals for a very long time, I confess I don't really understand why it has persisted, other than that no single entity has a very strong incentive to be the one that says, okay, we'll give up our system and adopt yours. And consequently, each of the insurers has, at least until recently, has had their own forms and their own procedures, and therefore physicians and hospitals have had to go through a variety of different hoops. The big difference, I think, between healthcare and all the other industries that gentleman mentioned is that this is the one industry in which the goal of policy, both private and public, really, is to protect individuals from financial ruination in the event of serious illness. That's called health insurance. We're not insured for computers or food or automobiles or anything else. Every developed nation in the world has a system in which virtually everybody has that sort of financial protection. Once you're into that world, you have, by definition, short-circuited out the price mechanisms that operate so beautifully in most of private economies. And therefore, you're driven to some form of second best, third best method of limiting spending.
Yep.
And in this case, you have very weak incentives for uniformity. There is a role for the public sector, as we've recognized, in establishing uniformity where uniformity is efficient. We do so in telecommunications. We do so in certain forms of public transportation. There used to be, in the case of railroads, we established standard gauges and so on. What is missing here, I think, is a sensible involvement by the public sector that could help simplify these billing arrangements that are a characteristic of the current system.
What?
There's one other point. Could I just make one other point? We're focusing now on cost. There's another thing which is rather important in the case of healthcare, and that is the quality of healthcare. I'm going to put out this fact, which is something that we all have to come to terms with. Very, very careful recent studies have found that during a random visit to a physician or a random hospital stay, on the average, Americans receive about 55% of the recommended care for the condition that they have, barely more than half. That startling number is almost the same whether you're rich or poor, black or white, male or female, old or young. There is one group in the United States for which the percentage of recommended care is significantly higher, and those are patients of the Veterans Health Administration. If you look at the arrangements, the organization of the Veterans Health Administration, it is the one example in the United States that really looks like the British National Health Service. It's a government-run organization. It used to be a total disaster. What happened over about the last 15 years is that Congress improved incentives and gave administrators in that system more flexibility than they had previously enjoyed, and the system was revolutionized. And right now, one can make the case it's the most cost-effective system of health delivery within the borders of the 50 United States.
Well, it's a very provocative example, and I'll when we're done, I'll ask you to email me something we can post to read more about that.
Okay.
I'm a little bit of a skeptic. I'm a skeptic of the 55%.
I can tell you one source that you might take a look at, an article by Adam Oliver called "The Veterans Health Administration: An American Success Story?" ? Which appeared in the Milbank Quarterly, which is a health quarterly, comes out, has been published for a long time. Volume 85, number 1, 2007 is the year, pages 5 to 35.
Okay. Well,
you can probably find that on the web.
Okay. Well, and if we can, and if it's publicly accessible, we'll put a link up to that. I want to go back to something you said a minute ago, though, and challenge you on it, because I have a different perspective. You said that one of the reasons that there's so little administrative efficacy in the healthcare area is because it's so insurance dominated. But we do have insurance for some of the items you mentioned: homes, autos, to protect us from financial ruin. Catastrophic insurance, which is real insurance, is not the aspect of our system that jumps out at you. What jumps out at you in the current system is how much that's covered that isn't catastrophic and financially destructive, things that are covered that would not be covered under a private insurance system. Of course, we do subsidize the private insurance system through the deductibility of employer-provided health care, which I think is a mistake. Mm-hmm. But what's interesting, and we'll close with this, is that, as you point out, almost every country does something like this. They create a security blanket for their citizens rather than what we would normally call insurance for catastrophic financial ruin. Robin Hansen in the previous podcast gave a very evolutionary and fascinating argument. It's not persuasive to me, but it sure made me think about it, and I encourage our listeners to turn to that. But what I would mention to you and to get your reaction is that, true, it's internationally common, but it wasn't always thus. As we pointed out earlier in the Arnold Kling podcast, a mere 50 years ago, Americans paid more than half of every health care dollar out of pocket. We made a deliberate or undeliberate, I don't know, move in the opposite direction, where that number is now closer to 10 to 15 cents per dollar spent is coming from the consumer. So I'll let you react to that comment, and two, I want to close with your ideas on which direction you'd like to see us move. As you wisely pointed out a few minutes ago, nirvana fantasies about the ideal healthcare system, whether they're the wool handler and colleagues kind of a single-payer system, or mine, which is a much more privatized system, are not realistic in the short run. Realistically, we will move incrementally. If you were healthcare czar with some political restraints of realism, what direction would you move?
Well, let me start with the cost-sharing point that you just made. That happens to be exactly the point that one of my colleagues here at Brookings, Jason Furman, made in a paper that was recently released through what we're calling the Hamilton Project here. he points out that the percentage of healthcare spending paid for out of pocket in the United States not only has fallen greatly, but now is lower than that in most other developed nations. Although they have complete coverage of major expenses, total cost sharing is actually larger in many other countries than here. If you're interested in that, one can find his article on the Brookings website under the Hamilton Project, F-U-R-M-A-N. Jason is the first name. He's the director, and it came out last summer. Now, if I were czar, I consider myself a political liberal, but on this subject, I have been working jointly with Stuart Butler at the Heritage Foundation, who is very definitely not a liberal. He's a very strong conservative, because we have the same perspective on how best to move ahead to reform the U.S. healthcare system. We both recognize that there is an ideological division in the United States. No single approach commands majority support. That and a number of other factors have frustrated efforts for national reform for at least 75 or 80 years. And we think, notwithstanding the sense that maybe now the time has come, we're doubtful.
Yeah, that feeling comes along about every 4 years, and it passes.
Well, actually, I likened it, as did a fellow at AEI, to periodical cicadas, which have a somewhat lower frequency, but in both cases it occurred to us that a lot of noise, not much to show for it, and then things go underground, and it's...
And lots to sweep up after they're done, actually. Lots of husks.
So both Stuart and I have urged that what the federal government should do is encourage states to move ahead in any of a very wide range of possible approaches, including favored plans of conservatives and liberals alike. Massachusetts did so on its own under Governor Romney with a Democratic legislature, and that was the key for us. We thought that it was important that this approach be bipartisan in character, both at its inception at the national level, and that the national approach or the national encouragement countenance actions that were very different in different states, so we can find out what works best and maybe make some progress in that way. The result so far is that there are 3 bills, each with bipartisan sponsorship and bipartisan co-sponsorship, 2 in the Senate, 1 in the House. The one in the House has about 70 co-sponsors, equally divided between Republicans and Democrats. I think that there's a lot we could do if the states were encouraged to move ahead to extend coverage in different ways. And if they do so, we'll learn something, and I think it would change the national debate.
Well, I'm certainly pleased to say I think that's a great idea. Experimentation and more information on what works and doesn't work would certainly be an improvement, a step that's plausible, realistic, and might actually help us make better decisions. My guest today has been Henry Aaron, Senior Fellow at the Brookings Institution. Thanks for joining us.
Thank you for having me.
This is EconTalk, part of the Library of Economics and Liberty. For more EconTalk, go to econtalk.org, where you can also comment on today's podcast and find links and readings related to today's conversation. The sound engineer for EconTalk is Rich Goyette. I'm your host, Russ Roberts. Thanks for listening. Talk to you on Monday.